Right, thank you very much, and thank you very much to the Oxford Biomedical Research Centre for asking me to come and give this public talk. It's not very often you get the opportunity to relax a little bit and give a talk which has a broader interest and allows you to present some of the ideas which you very often present within quite a strict kind of research or scientific setting. And one of the things that I'm going to immediately break from tradition is, for my opening slide, I'm going to bring forward what I usually put at the end of a slide, which is actually acknowledging what I'm about to talk about is not really all about me. It's about actually what has made it possible to do this work, and that comes down to the support of the University of Oxford, the support of the Oxford University Hospitals Trust, the support of other institutions outside Oxford, and obviously the support of the Biomedical Research Centre in terms of funding research that's going on. Probably most importantly is the people who we work with, the team who actually do the research on the ground and seeing patients all the time, and also some key funders who really support scientific activity within the UK, particularly in our field, British Heart Foundation for our work in cardiovascular medicine, and also the Wellcome Trust, which has a much broader remit. So I think that's really important. When we talk about this research, this is about that really, and about what that makes possible. I'm going to start with a picture quiz, if you like. This is a couple of pictures which, to be honest, I wouldn't have been able to recognise before I started preparing this talk. I was just wondering if anyone in the audience knew who this was, or could throw out a name for who they think this is. Mariah Carey, superb, excellent, very good. Okay, here's another one. Maybe slightly more tricky.
Kim.
Look at that. Everybody knows Kim Kardashian, apparently. So why have I just shown a picture of Mariah Carey and Kim Kardashian? Any thoughts? Any? Sorry? They're mothers. Excellent. And do you know anything particularly about these mothers? The great thing about celebrity is you know an awful lot of detail about these individuals at a level which you wouldn't normally ever know about other people around you or people sitting in the room.
Did they have preeclampsia?
Exactly. So both these celebrities had preeclampsia during their pregnancies. And what preeclampsia means, and it's what we're particularly interested in, is two things. Firstly, what it means is during their pregnancies, their blood pressure shot up very rapidly over a few weeks. What also happened was, and this is kind of a tasteful way of representing it, is they started to pass a lot of protein in their urine, what's called proteinuria. And you can pick that up with these dipsticks, which pick up how much protein there is in the urine. And the consequences of that is that you often get some edema, increased edema when you're pregnant. And this was one of those photographs which appeared in the press at the time. More severely, if you let it carry on, one of the problems that develop is you start to get edema elsewhere, in the brain and elsewhere. And if it goes unchecked, you can start having strokes, you can start having fits. And indeed, what used to happen is people used to die from preeclampsia during their pregnancy. And the other really important complication is that very often, because it gets so bad, you have to deliver the baby early, or the baby comes early automatically, and so there's a much higher rate of preterm birth and growth restriction in the babies which are born. So, preeclampsia is something which we have been able to diagnose and characterize really within the last 50 or 100 years. But actually, if you look back through medical texts over thousands of years, the features and signs of preeclampsia have been reported for for a long, long time. So this is just a text from a Greek textbook well before, well into the BC era. And they describe a condition in pregnancy: drowsiness and headache accompanied by heaviness and convulsions is generally bad, which doesn't sound great, does it, actually? So this is something which has been with us for a long time. It affects about 10 to 20% of pregnancies. So it's not that rare either. It's quite common. So there are a lot of people around about who've had this condition. What happens in preeclampsia? Now, it's one of those things that we've also learned a lot about in the last 50 years, but we still probably don't fully understand, to be honest. There are lots of theories about it, and we haven't quite got to the crux of it. And one of the signs that we haven't got to the crux of it is, in reality, we really still haven't got any good treatment from it, apart from bringing the pregnancy to the end by delivering the baby. What we do know, we suspect, is that it probably comes from something going wrong with the placenta. and something very, very early on in the pregnancy, within the first few weeks. And studies which have been done on the placenta, you can look at the blood supply, how the mother's blood vessels start to interact with the vessels coming from the baby. And what seems to happen is that the blood supply, it doesn't work for some reason. So there's very poor linking of the blood vessels between the baby and the mother. It's still enough for the pregnancy to continue, but it's not as good as you'd expect. As a result of that, the placenta doesn't really get enough blood for what it needs, and it starts to react. And it starts to send signals that are kind of ischemia type signals, so signs that it's not getting enough blood and oxygen. It sends out signals of increased oxidative stress. You can get factors which increase or decrease the angiogenesis, so that's the stimulus for developing blood vessels. You get release of little particles, the sensitivity of trophylline microparticles, into the blood, and they circulate and cause problems. And you get generally a systemic inflammatory action in the pregnancy. And as a result of that, your blood pressure goes up, your kidneys become leaky, and you start to lose protein, you start to get edema, and you also get this leakiness and problems in the brain. So clearly I'm a cardiologist, I'm not an obstetrician. So one of the questions is, why am I so particularly interested in preeclampsia? No, 90% of the patients I see, or probably 95% of the patients I see, aren't pregnant. They're just adults with different types of heart disease. And it comes down to what I was talking about those blood vessels and how those blood vessels form in the placenta. So if you go and look at a placenta, and you look at the blood vessels inside the placenta after an episode of preeclampsia, you find things like this, and this is an example of what's termed called anatherosis. So there's thickening of the vessel wall, there's lots of stuff inside the vessel, there's lots of inflammation, and there's lots of blockages of vessels. And the striking thing about looking at a placenta is you can take vessels from elsewhere in the body and see similar kind of things, so thickening of vessel walls, stuff inside the artery, blocking it up, and encroaching. And this is a picture which is taken from someone with heart disease. Interestingly, this is actually taken from someone who was quite early in life, in their 20s, who had heart disease. Hence, it's taken from the 1950s in someone who had died from other causes, not from heart disease. And so we can see these changes in vessels are happening quite a lot, all the time. And there are similarities you can see in the vascular disease you get in preeclampsia and the vascular disease in heart disease. And that's why we're particularly interested in it, in terms of understanding what those links might be. So what happens at the end of pregnancy is your blood pressure usually settles slowly over a few months. The proteinuria disappears. Your baby is delivered and it's hopefully growing very well. The edema settles and you go back to functioning normally within those months after pregnancy. But what we know is there are these links between what happens during the blood pressure during pregnancy and heart disease, because we've seen those vascular links. So what has become apparent over the last 20 years is that people have asked the question, well, if you have all these problems during pregnancy, does that mean you're at risk of heart disease at other points in life? And there have been quite a few studies now, large-scale studies, which have followed up women looking at incidents of heart disease, other problems in women who've had hypertensive pregnancies or preeclampsia. And the very striking thing is that if you follow these women up over the next 10, 20 years, their risk of going on to then having hypertension again, either the blood pressure problems re-emerging, they're about 4 or 5 times more likely to have blood pressure problems. More strikingly is they're about twice as likely to have a stroke in the next 10 or 20 years. And they're also more likely, about 2-fold more likely to have heart disease, heart problems. They also seem to have higher rates of kidney disease, high rates of diabetes. And this is so well accepted now that recent guidelines for the last few years actually include, in cardiovascular medicine guidelines, are now routinely including a history of preeclampsia or pregnancy complications in how you assess risk in women. Both with regard to stroke, but also cardiovascular disease. The most recent guidelines from the European Society have included hypertensive pregnancy complications as one of those things we should be considering now in women as a risk factor for later disease. Both in terms of interpreting, monitoring, keeping an eye on these women so that when a disease emerges, we can better manage them. But also it raises questions whether we actually should be more proactively trying to follow these women up. And this is probably where we came in. So we were interested in what was happening in the women, but actually what our real interest was, which we started looking at about 5 years ago, was something else. And that was this. So for in each of these pregnancies, there are two people. There's the mother and there's also the child. And one of our questions we wanted to ask was, well, if the mother has such a bad time and is at risk of these heart problems, what about the child? How do they experience? What we know is this time in life, during those 9 months of pregnancy, you change and grow incredibly rapidly, and for a few months after delivery. And what we know is very small things during this period of rapid development, such as a mosquito bite to the mother, can have a huge impact on what's going on in the development. And this is an example of a mother who's had a Zika virus and a child who's had developmental abnormalities as a result of that. More commonly in the UK, we have some problems like this, which we have found ways to manage. And this is an example of rubella virus, which we also know can have quite dramatic effects on offspring. So if during a preeclampsia pregnancy you have all these great problems with the placenta, how is the child dealing with that, and is that relevant to their health? Well, we start off by looking at what we knew out of there, and there were some clues that this was worth looking at in some more detail. This is a particular study which was published back in the early 80s, one of the earliest sort of proper studies we could pick out, really, which was done in the US. It's done in a place called Techimesh, which is just in Michigan. And it was one of these population-based studies where they looked at everybody in Techimesh and just watched to see what would happen and understand the cardiovascular risk. It's a forerunner of some of those bigger studies like the Framingham Heart Study, which has been a very major key study to look at cardiovascular disease. But one of the things they'd looked at, which other studies hadn't done at that time, was they'd asked that question actually about what would happen in blood pressure in offspring of mothers who'd had toxemia. And this is their blood pressure data. So on the, I haven't got a pointer actually, but on here this is the level of blood pressure. And they were looking at the sons of these mothers. And you see the black bar is asking the question. These are sons who are in their early 20s. And they asked the question, if you were born to a hypertensive pregnancy, this is actually decades of life, did you have higher blood pressure than those whose mothers had no normal blood pressure problems, or if their mother had a hypertensive pregnancy, but actually had previously had a hypertensive pregnancy, but had a normal hypertensive pregnancy? What they found was those sons who'd been born to a hypertensive pregnancy appeared to have quite a significant higher blood pressure, which emerged over the first few decades of life. To be honest, after that study, the people seemed to lose a little bit of interest in this for quite a while, but then there was a resurgence of it, such that we decided a few years ago to actually just try and bring together all the studies we could find in the literature for this. And actually, once you looked at the literature, what we could find data on about 45,000 individuals which had been reported separately in different studies. And we could bring those together in a meta-analysis to try and understand exactly what the effect might be. And indeed, consistently across studies, across nations, across different areas of the world, all those individuals who've been born to hypertensive pregnancy also had higher blood pressure in childhood and adolescence. And we looked further. We did a study here in Oxford which asked the question, well, if they have higher blood pressure and their blood pressure is rising, how does it compare to the mother? And what we found was there's quite a nice association, or clear association. Those mothers who had more rapid rise in blood pressure, their children also had a more rapid rise in blood pressure. It matched together. Furthermore, we went to a cohort in Australia and followed and looked at some of the data that was available from that cohort collaboratively, about 3,000 individuals born in Australia. And we asked a different question. These are cohorts being followed up from birth into young adulthood. And we asked not just, have they got higher blood pressure, but actually are the blood pressures at such a level that you might actually say, well, this person has hypertension, even though they're only in their 20s. And when we think about hypertension, we suggest its blood pressure is greater than 140/90. So there's a nice cutoff to define that. Now that's relatively unusual in people in their 20s. About 1 in 17 people in their 20s will have a blood pressure at that level. And what we found was in this cohort that had been followed up from birth, if you'd had preeclampsia, actually 1 in 5 of those people already had blood pressure within hypertensive range, even though they weren't necessarily being treated for that by the time they reached young adulthood. So it's increasing their risk of that threefold. And then interestingly, there was also some work being done in Scandinavia, which was published around the same time, which had followed up a cohort which was born quite a long time ago and therefore in later life. And they, because of their way they collected their records, they could have had captured some information about what had happened during the blood pressure of the mother during the pregnancy. Now, this was a cohort from a time when actually if you were born preterm, you didn't really survive. And so actually most of the women in this stage, most of the offspring from this stage had actually been born quite late on in pregnancy, and the mother's toxemia, preeclampsia, hadn't been quite as severe as we might see these days. But even in this group, what they found was that when they reached later life, they were also twice as likely to have had a stroke, and they also had an increased, although smaller, risk of having heart problems. And there's a final interesting little twist to this as well, which is actually a study also asked the question, what if this person who's had preeclampsia then goes on to have their own pregnancy? What happens during their pregnancy? And, or rather the offspring of the pregnancy, what happens if that offspring then goes and have their pregnancy? And fitting with the story, those individuals also much more likely to have preeclampsia during their own pregnancies. Hence the title of our talk, which is, if you know something about the mother, you also automatically know something about the child from very early on in their life. So having established this, we decided to look a bit further, and we asked the question, and we wanted to pose this interesting question, try and see if we could understand more about this. So this kind of encapsulates the areas of life which are interesting to study in this question. First of all, you have a mother who has a pregnancy complicated by a complication of some particular hypertension, and they go on to have cardiovascular disease in life. Their baby also may have a different development of their cardiovascular system. As they grow up, they may develop cardiovascular disorders. As they go on and have their own pregnancy, they have preeclampsia. And all these individuals have some kind of, there's something about them which makes them more at risk of blood vessel problems. So I'm just going to take you for a moment and think, why might this be? And that's often a question that you ask about this area. Well, that's really interesting. Why might this be? And the kind of answers people come up with was, well, it's all just in the genes, isn't it? Or, well, maybe they're just all, it's lifestyle. We know America's lots of obesity problems in America, that they're probably just all larger, aren't they? They all eat too much. Or the question we came in, our starting point, which triggered our interest, was, well, actually, could there be something different about how they're developing these babies in the womb? I think the reality is we don't yet know, actually, which of these three things are the key parameter. My intuition or sort of best guess is that the lifestyle probably isn't hugely important. It is probably important in what modifies what's going on. So actually, if you smoke or you have levels of deprivation or everything, it probably makes things worse. But what we know from here in Oxford, and because actually we're quite a healthy bunch in Oxford to some extent, we tend to have quite healthy lifestyles, is that actually we see as much preeclampsia hypertensive pregnancy in Oxford as we do anywhere else. The people I see in the hypertension clinic after their episode of hypertensive pregnancy, they usually have a normal body size, very often will have a normal body size, they're exercising, they're doing other things. So lifestyle may affecting, most of the data suggests it's not really having, it's not really the main driver. Genes is interesting, and it may well be the case, and I suspect there has to be some genetic influence on the process. And I think what we struggle with the gene side is there have been lots of tries to try and understand what the genetics of preeclampsia are over the last 10 years. And although we hear great headlines about cardiovascular disease, diabetes, there's still not a good study which has shown any great genetic influence on preeclampsia. So we're still struggling to pinpoint that. But you kind of guess there must be something, and we clearly see this running in families. It's complicated by the fact that actually we share a lot. There's a lot going on between the mother and the baby, beyond genetics in terms of sharing of information. One of the amazing kind of bits of observation are things such as, if you look at mothers 5 years after having had a baby, and you can see this in animal models or other settings, actually, you don't just, and if you look at their heart, what you actually find within those hearts are actually cells from the baby themselves. So there's an awful lot being shared between the mother. If you look at their brains or their livers, you see this what's called microchimerism. So if you've had a baby or you've had a couple of babies, then certainly for the next 10 years, you will share some cellular material with your baby long term, which is quite a thought, actually. So it may not be as simple as just saying a genetic thing there. Developmental story has had a lot of interest over many decades. Clearly there are birth weight effects which have been linked with heart disease. We still don't fully understand that. But clearly if you have a lot of problems during pregnancy, it's going to affect your development in some way. So I suspect it's probably some combination of the genetics and the developmental processes which are driving this risk, potentially modified by the lifestyle. But that's my best guess, and the work goes on. Because it's a complex area, I guess in our research, we've tried to sidestep this point to some extent and come from a slightly different angle, which is if we know this trajectory of problems, and we know right from birth that these individuals are at increased risk of stroke and hypertension, why don't we try and start doing something about it straight away rather than focusing too much on the academic question of what particular mechanistic pathway we're trying to pick up? Is there ways we can intervene? And one of our thoughts about how we might be able to do this is how we started was asking the very question, well, let's just have a look at see what is unique and special and different about the mother and their child in terms of how their cardiovascular system is set up. So it's a very kind of basic scientific approach. It's about observation, but observation at a level we weren't able to do some time ago, and we can now do because we have support and infrastructure like those and the funding like we saw at the beginning. And so we took an approach that we would try and study the cardiovascular system in as much detail as possible. And the great thing about Oxford is we can do echo imaging, so we can do ultrasound imaging, which gives very nice, precise images of the heart, kind of look at how the heart's functioning. We can look at blood vessels using ultrasound imaging, looking at how thick they are, how they change in behavior. And we don't need to just look at big vessels. We can go down to a microscopic level and look at very small vessels in the eye, which is the top image. We can look at in the skin, at microvessels. We can take blood samples, that's the easy bit. We can also monitor blood pressure during the day. We can look at heart rate, how heart rate changes. We can look at how people exercise, how fit they are, how much exercise capacity they have. We can look at stiffness of vessels. We can use more sophisticated imaging techniques like magnetic resonance imaging, which allows you to look right in at the myocardium and study what's going on. And you can look at the brain, you can do brain imaging. So we have a great opportunity to look at these studies. So what we did was we designed some studies to look at mothers who've had preeclampsia, to look what happens during pregnancy, to look at the babies when they were born, and to look at some young adults before they're even pregnant. And what we decided to do was try and measure as much as we could. So the study visits are quite comprehensive, but we've involved several thousand individuals in these studies now, and the data is incredibly rich in terms of what we can learn about what's going on. So what I want to share with you today is a couple of insights of the journey over the last few years that have given us new thoughts about what might be going on. We know they're at risk, and so what we're keen to do is identify that so we can do some targeted interventions and quite focused interventions. Where I'm going to start is in our young adult cohort. So these are people in their 20s and 30s who either have perfectly normal backgrounds or have a family history of hypertensive pregnancy, or indeed were born from hypertensive pregnancy. And obviously within that, what you capture is individuals who are born preterm as well, because there's a high rate of preterm birth in preeclampsia. And what we also captured were those who were born preterm without a background of hypertensive pregnancy. Our sort of hunch was that if preterm is such a dramatic thing for a baby to experience, then actually it probably is going to affect how they develop. If you're taken from the womb outside a couple of months early, all your development should be normally be occurring under via the placenta within the womb, has to suddenly occur in what we call ex utero, so that physiological state within an incubator. And your left heart, and your lungs, which aren't usually functioning in the womb, suddenly have to start working, and you get huge changes in hemodynamics. So you kind of think something should be relevant there in terms of what's going on with their hearts. And we took these young adults and we performed cardiovascular magnetic resonance imaging, which produces images like this. They're very nice, precise images of the heart. On the top, you can see the four-chamber view of the heart. We can see the left ventricle is kind of at the bottom, the right ventricle at the top. The two views below are different types of cut through the heart, so you can look at how the blood's leaving the heart through the aorta and a couple of the other walls of the heart. This allows you to look at how well the heart's pumping. You can also do very detailed measurements, so you can actually look at the weight of the heart, both on the left and the right side. And you can also, like I say, drill down and look at actually the muscle itself to see whether there's anything different about the muscle. You can see, does it have a lot of fat in it? Does it have a lot of fibre in it? What makes up that heart muscle? And what we did, was having done these MR images on a couple of hundred young adults, we brought that all together and using a computational approach, we basically created a picture of what the average left ventricle would look like for an individual. And this is basically it. So if you're a young adult in your 20s, this is kind of an average shape of what your left ventricle is going to look like. That's kind of size, wall thickness, the chamber size. To compare, we looked at a group that were 10 years older just to see what happens with aging. And you can see there's some subtle changes. So the ventricle becomes a little bit, the chamber becomes a little bit bigger, but not hugely different. And then what we did was we did the same thing for individuals who've been born preterm, and we sat that alongside. You've got to remember, these are individuals who on the outside look pretty much similar. They're not particularly shorter or different size, but they're similar body weight. But actually, if you drill right down and look at their hearts, what you can immediately see is that they are quite uniquely different. So they're shorter, their wall thickness is bigger, and their chambers are smaller. And so what we've stumbled across in our interest about hypertensive pregnancy was actually, if you've been born preterm, you have quite a different average cardiac shape and size than someone who hasn't, even though you may not be aware of it. You have increased cardiac mass, and if you look at the function, you actually have slightly reduced heart function. It doesn't quite pump as effectively. And you see this not on the left. We went on to look at the right heart, and the right heart is the same. It is, again, reduced in size. It's thickened up, and it doesn't pump effectively, which is really interesting because one of those observations that have been out there, which is people have noticed, is that actually, for some reason, people who have been born preterm don't seem to have quite as good an exercise capacity as other people, and it's been proved difficult to explain that. And so what we're doing at the moment is exploring whether actually these cardiac changes we've picked up could explain some of those other observations that have been made in preterm individuals. We wanted to know when this might happen. So if you look at a young adult population, you find they have greater cardiac mass, and changes in shape. The next question is, well, is that just something that's developed as they've grown older for whatever reason? They have slightly higher blood pressure, we can see that, although the changes are out of proportion to their blood pressure. Or is it something that happened early on? Our hypothesis was that it would be something to do about the fact they'd had to transition out of the womb to the external world early. And this was some kind of adaptive response to having to cope with the extra stress of being outside the womb. And so we did a study which involved about 600 babies, tracking them from during their fetal development through into 3 months post-life, and we did echo imaging on these individuals. This is one of those participants' hearts, and what we've been able to do is track its movement. You can see it beating away. Just to give you an idea of the scale of what we're trying to measure here, I've put a mass down, which just doesn't help us a bit. So what I've given you is an example of a similar type mass. So if you look at a regular M&M, it's slightly smaller than the fetal size we're trying to measure. If you look at a peanut M&M, then it's actually a little bit bigger. But that's the kind of scale we're measuring in terms of size and weight and trying to look at. What's a nice thing about ultrasound imaging nowadays is you really can capture that kind of detail with high reproducibility with some of the ultrasound technology they have. So what we did is track that growth. What I've shown you is two figures. One is this is of the left ventricle on the right, and on my left rather, and on our right is left ventricular mass, which is proportional to head circumference. So one of the things is obviously the heart is growing, and if the body is growing in different rates, you want to be able to adjust for how quick the body is growing. So if you use head circumference, it's quite a good way of sort of averaging it. What you can see is grey is what we've shown is the trajectory for what changes in LV mass in babies. And actually we hadn't really ever studied this in great detail before, so we were able to build trajectories. And what we saw in the blue is actually what's happening in the preterm infants. And you can see a cluster of dots when they were born a little bit early, just here. And what you can see is that during this phase, while they're still, before they're born, they're perhaps a little bit smaller. So there might be something going slightly unusual in this pregnancy, which might be why they're born preterm. But if anything, they're a little bit smaller, and they're within the range you might expect. You probably won't pick anything. But after birth, they suddenly shoot up. And you can see that more pronounced in the group, so that actually by 3 months, they're starting to have masses which are bigger than the babies who are born at term and larger. So what we want to do is follow these through and track this through. But what it does support is the concept that actually during the first 3 months after life, it might be a critical period for managing preterm babies in terms of how you optimize their cardiac development. And we decided not to stop there. So we thought about this. So if this 3 months is really critical, is there actually already something we can do which might be able to help these babies? And is the knowledge we already have which could look at this? And of course, one of the key things which happens during this period is that babies are fed. And it's one of those really moments in life where, you know, we're not eating huge varied meals, all sorts of things. You basically have one food substance. You know, you have milk. And you get that for a period of life in a very controlled way in terms of the amount of milk you get, when you get it. You don't have much control over it, so you'll provide it. So one of our questions asked is actually how they're fed. Could that be influencing how their heart is developing during this period? Because what we know is that breast milk has lots of great growth factors, there's lots of interaction in terms of what's going on. So you'd kind of hypothesize that maybe breast milk is perhaps many more beneficial for cardiac development during this period. Interestingly, what we had is we could go back to some of our data of a trial that was done some time ago, not by us, by a group in UCL, which is one of the collaborative groups who'd set up a trial back in the 1980s, where they'd actually randomized individuals to either receiving fortified milks or breast milk, which is actually banked breast milk. And it's kind of one of those studies which would be very difficult today because at that time, it didn't seem unreasonable to randomize babies to different feedings because we didn't have quite the same kind of feeling that everybody should be breastfed. But there was this cohort we could look at which had this randomization. And we could go back and look at their hearts in young adults to ask this question. So if that 3 month period is really important, then actually how you are fed during that period should be influencing how your heart's developing. Because from then on, everybody's eating things much the same. I'm going to bring you back this. So this is our average heart. And this is our average size heart. And we first looked at the group who'd just had formula feed, and we could see the classic pattern we'd expect to see in a baby who's been born preterm. And then we looked at the group who'd just had human milk, so no formula feed at all, just been given human milk. What you can see quite nicely, is, you could just see it even by eye, you don't need necessarily the statistics, is that it's already beginning to move towards the shape we'd expect to see in a healthy baby. And these are the same gestation born preterm babies. And that was really exciting for us. It doesn't correct all the changes, interesting. You can learn all sorts of things. The mass is still as thick. There's something going on in the heart muscle which we don't correct. But certainly the size of the heart and the function of the heart is improved in these individuals who'd received human milk during this period. So that was great. We started off 3 years ago saying, with the news headlines saying born prematurely, risk heart failure as an adult study suggests. And the great thing about having this data and these collaborations is that in 3 years we can move on, and we're suddenly having news stories saying, actually, look, breastfeeding helps premature babies' hearts to grow. Study finds. So we can move from that question, is there something wrong? The question to say, well, actually, there is something wrong, but actually we can move then to say, well, actually, this might be something we can do about it as well. It's not, this isn't conclusive data, but it adds significant weight to the idea that we should be optimizing nutrition for these babies if we want to improve their heart health. Great. So, having said that, I want to bring us back to where we were before. So what I started about, just before I started getting drawn into talking about premature babies' hearts, is actually what we're interested in was hypertensive and heart disease and why that causes stroke and blood pressure problems. So one of those great things about it is research is you start out on a process, and you often find these interesting observations which you just feel you have to pursue and work out. So actually the question about high blood pressure and stroke wasn't answered by that whole piece of work about heart disease, but we did find something new about preterm babies, and we did find something which might be very important, how you improve the function of the appropriate babies. But we need to go back. We need to keep focused on what we're wanting, which is talking about what can we do about hypertensive pregnancy mothers. And so the other area we're interested in looking at is at the other scale. So obviously at the start of the blood flow, you have the heart. At the other scale, in the skin, you have the smallest blood vessels in the hand, the microvesicles. And this is actually imaging of one of the research fellows' small blood vessels in the unit. With nice microscope techniques, you can see this in anybody, actually. You can see these smallest blood vessels in anybody without needing to do anything terribly fancy apart from imaging and focusing down on these blood vessels. And you can see in the nice resolution, you can actually see these are individual the red blood cells are the black bits and the white blood cells are the white bits. So you can actually see these blood cells moving around the body, which is quite fun. And the reason we wanted to focus asked another question, which was actually, if, the hearts are interesting, but actually if we want to get the blood pressure, what might be different, is that the small blood vessels are very important for blood pressure control. So the amount of small blood vessels you have can determine what your blood pressure is, because it's a way of, because there are so many blood vessels, it's a way of buffering the blood, controlling the blood. So it if you get less small vessels, we can see in people who are hypertensive, their blood pressure tends to be higher. And so one of the questions we asked was, what's going on with their blood vessels? And the reason we were particularly interested in this was things like this. So this is a bit of data, interesting, on a study of a drug which is used for cancer. So the drugs which are used for cancer sometimes are designed to be able to interfere with how blood vessels grow and develop. And this was a study which we know happens with these kind of drugs, which is that if you start the drug, what happens is one of the side effects is your blood pressure goes up. And your blood pressure goes up, and if you look at the amount of blood vessels, the capillary density, your blood pressure goes up as your capillary density drops down in response to this drug. And it's a kind of, you give the drug, this happens, and then you can recover to some extent if it's stopped. And what was interesting to us about this was also, this is the similar kind of data, but it was reported in women who had preeclampsia. So this is a group who blood pressure goes up, and they'd looked at what happens to their small blood vessels during the pregnancy. And what you can see is they lose small blood vessels during that pregnancy as their blood pressure rises. What's more, we were talking about how there's such this interaction in the placenta between blood vessels and how they grow, and clearly they're not developing quite properly, and so there's something going on at a vascular level in terms of these cells. And the other thing which brings us back to something which is also something we've talked about is this. This is my final pitch quiz. So anybody want to shout out who this is? Stevie Wonder. Does anybody know anything about Stevie Wonder's history? Sorry?
He's blind.
He's blind. Does anybody know why he's blind? This is one of those facts. So Stevie Wonder was born preterm. And one of the complications preterm babies get is they get problems with blood vessels in their eyes. They're called retinopathy of prematurity. And so we see this with these development of blood vessel problems in preterm babies as well. And so there seems to be a consistent story around something going wrong with small blood vessels which might be relevant here. So we did a study, the same study we'd looked at hearts. We also looked at their small blood vessels in these babies who are being born, this kind of 600-odd babies. The great thing about studying small blood vessels also is that, very kindly, mothers will also be willing to donate their umbilical cords. And the umbilical cords is basically connected to the baby, it's part of the baby, and it contains blood cells and blood vessels from the baby. So we can take blood cells from the umbilical cord, which actually reflect blood vessel cells from the baby. And we can grow those up and study whether they behave differently. We can also use these imaging techniques to look directly at the blood vessels in the skin. And this is an example of one of those images showing the network of blood vessels. So we can look at how the blood vessels are developing very early in life. I'm going to show you a bit of data which we published this year. So this is getting quite recent now. So what we looked at was, I first asked the question, well, is there any difference in their blood vessels when they're born, these babies? And what we found was actually there wasn't an awful lot of difference in how these blood vessels were when they were born. But then we followed them up to 3 months of age, look at how the blood vessels then adapted to their environment after they were born. What we found was that if you looked at a baby who's born at term to a mother who had normal tendency pregnancy, very healthy pregnancy, it doesn't change a lot. You actually lose a few vessels by about 5%. And that's because when you transition from being a fetus baby into being a baby, you have to adjust, and there is a remodeling of your small blood vessels that occurs during that period. So you do lose a little bit, and that's known about. What happened in those who've been born to the mother who's hypertensive is that the loss of vessels was much greater over those 3 months than you would expect. Otherwise, the baby was doing okay. So you wouldn't, unless you'd actually looked, you'd never have known this was really going on. But they had about 3 times greater loss of blood vessels during this period. And this is true whether you were born term or preterm, born to hypertensive pregnancy. And what's interesting, which is another observation, is it also occurred in those who've been born preterm, even if their mother hadn't had hypertension during the pregnancy. So there's clearly something different going on, how these blood vessels are developing. we have those cells from the cause as well. So we thought we'd look to see how the cells behaved compared to how you lose your blood vessels. What we found was there's quite a clear association which tracks upwards. So if you look, so if you have a 30% loss of vessel density, which is quite a lot of loss of density, then actually the ability of your cells to grow tubules and then function within a test tube or within a matrigel dish is significantly less than if actually you have not much vessel density change and your vessels grow much better. So that actually the behavior of the cells in these individuals is very different. It's not just how the blood vessels are developing. And then we looked to see whether it was relevant to the mother and how severe the problems were in the mother. And what we found was that if you look at something which is released by placentas which are under stress and is a marker of stress, which is something called soluble flit, which is one of those markers which are circulating in preeclampsia, what you found was that actually the higher that level in the mother at the end of her pregnancy, the greater the loss of vessels in these individuals, which just is some direct relationship going on with the severity of disease in the mother and the severity of disease in the offspring.
I can't read what those coordinates are.
Yeah. So this is total vessel density change. This is a percentage drop in the number of vessels you have during those first 3 months if you're looking at the skin. Along the bottom, we've grouped the levels of soluble flit according to the percentile groups. These are in tenths of and over time, as you can see, as you get the higher level, you get a greater loss of vessels. What was also interesting, which is another observation which we're pursuing at the moment, is that even if the mother didn't have hypertension, but had signs of stress, so they had higher soluble flit levels, those babies also had problems in their vessel development. And what we know is there are some mothers who don't necessarily get full-blown hypertension, but do have stress signals in their pregnancy, which we don't necessarily see, might be slightly subclinical. And this suggested that actually what we might be getting is something, a signal of things going on, not just in hypertension, but in other situations as well, which is relevant to the baby. So we also have data from adults looking at vessel density, and as you might expect, based on what we've been seeing before, indeed in later life, they still have less vessels in their skin. And what's interesting is in this group, the levels of their how reduced the number of blood vessels are, the higher their blood pressure in that group as well. So I get back to this. So we know there's something different about the small blood vessels, and we have a lot more data which describes that in a bit more detail, but still what we're interested in is what can you do about this? And that really brings me to where we are at the moment, right up to date, which is what we're interested in is intervening in young adults. So there are different times you can intervene, but one of our interesting things is if these individuals by young adulthood, which I mentioned earlier, are about 3 times more likely to be hypertensive than their contemporaries, then actually this is a great moment. And what was interesting is these people turn up in my clinic. So I'll have young adults referred by their GP to my hypertension clinic with the story that these people have high blood pressure. We don't quite know why. They don't seem to have any obvious reason for it. And you sit down and you talk to them, and then you start talking about, well, is there any family history of heart disease? And I said, oh yeah, no, my mother had preeclampsia. And suddenly it makes sense about why these individuals are turning out with high blood pressure in the clinic. But still, we don't have any specific advice for these individuals. So we have some generic advice about what you should do for blood pressure. But if these people have a specific problem, we should be trying to be more focused and targeted with how we can advise these individuals. Remember, these are people who are very often normal body size. They're normally active. They're normally doing things. They're normally eating fairly healthily. So we can't give just routine advice. We need to give something more targeted. So what the moment is doing is a trial called TEFRA, which is running across Oxford and extending the Thames Valley. We're actually focusing on asking the question, well, if we're telling all these people to go and exercise, is that the right thing for them? So our standard advice to young hypertensives is go away and do a bit of exercise, but we don't know whether it actually works. So we're actually testing that. So we're going to say, send them away. Well, we do know it works to some extent, but actually, does it really work? Actually, beyond a few months, blood pressures don't work terribly well. So what we're going to ask is, does it work? We're recruiting these individuals, we're putting them through the exercise program, we're going to watch what happens to their hearts, what happens to their blood vessels, and so that hopefully we can give some more tailored advice to what's going on and how we can manage these individuals. 2 things, we'll learn whether we can give any specific advice, and the other thing is we can see actually how they respond to know whether we need to adapt that advice for these individuals. We are recruiting via an online system, which is something which incredibly effective these days, actually. So, you know, we used to send out letters to everybody, and people would get in touch with us. We still do that a bit. We used to put adverts in newspapers, but increasingly people aren't responding to these. So what we do instead is we use online advertising with a company Designed who works with online recruitment. And the beauty about this is we can be quite selective about who sees these adverts. We don't need to show them to everybody. We can show them to people who might really be interested in this. So we can use what people tell us on Facebook about themselves, that we can actually show them an advert. So if they fit the, so if you've seen one of these adverts, then the chances are where you have a Facebook profile, whether it's genuine or not, I don't really say, but you have a Facebook profile which is saying, I'm about 20 or 30, and I'm interested in things like hypertension. I may be interested in things about preterm birth, and those kind of things. And these will be, and also that I'm living in the Oxford region. So we can be selective about who we send these adverts. And it's great. So every week we're getting 50 or 60 people coming up and coming to the website who have just seen this coming up on their screens. So that's where we are. And I'm very keen to ask questions about what we're doing and talk further about where we're taking things. Thank you.